Webinar. Now I'll pass you over to Dr. Hamer. Hi, I'm Steph. Welcome to today's webinar. Now I'll pass you over to Dr. Hamer.
Thanks, Steph. And very good morning to everybody. I'm so happy to have you here. We are going to see about the antidepressants and depression today. And it's like a beginner's guide to rock your consultations and pass your exams easily. In this webinar, you will learn about the latest NICE guidelines about the antidepressants and depression management in adults, how antidepressants work, why they are prescribed, their effects and side effects and alternative treatments, how to choose the appropriate antidepressants and how to withdraw or change them, the patient-friendly way to answer the most common questions asked by our patients, and then we see some example cases, and finally I will give you some references and sources for further information. Tell us where you're from, and if you have come across any difficult, interesting cases, please share it in the chat box, comment box below. And my promise is to have fun today, to go, by learning this depression and antidepressants, which is a nightmare if we don't know the details, but it will make it very interesting to offer the best care for our patients if we know all these info. So stick with us. And your promise, please be present and turn off all the distractions and have a pen, notes, and water, and be ready to spend the next 1 hour with me. Right. Please answer the poll question. Which topic do you want in our next webinar? Share it in the comments box below. Thank you. You're in the right place if you're confused about the different consultation and communication models. You don't know how to prepare effectively for exams like MRC GP CSA, MRC GP International, and in other countries too, like Australia and Canada. If you feel overwhelmed and don't have the time to try and figure it all out yourself, you're not really sure what's working now in exams and need help identifying easy steps to pass it, you want to learn from someone who has personally achieved it and guide you step by step. And above all, you have a strong will and determination to pass your exams this time and rock your consultation forever. If you're wondering why is this not working, I can only say these 3 words. I can relate. As you all know, I'm a mom to great RB. I'm a GP in Yorkshire in UK. And I have got gold medal from President of India and other gold medals during school. And in UK, I have done lots of degrees and diplomas. And I have studied in all 3 countries like India, UK, and USA. But the truth is, I struggle just like you. I have gone through multiple books, attended many courses, did many diplomas, learned by trial and error what not to do and what to do, and ended up identifying what actually works in medical consultation. And during my training period, I thought like, okay, our knowledge is our power. So we need to bring this knowledge to my fellow students. And I started CSASmartGroup.com. Many of you know me through this free website. I started this just for doctors who felt like lost little Nemo, just like me. And I'm so happy that we have helped thousands of students all over the world, like more than 128 countries in the last few years. And then I realized our knowledge is not our power. Execution trumps knowledge every day of the week, as Tony Robbins said. So I started this CSA Smart Success online course powered by Consultation Skills Academy to help doctors to rock the consultations and pass the exams with confidence. And it has helped hundreds of students all over the world. Okay, the disclaimer is this webinar only covers a general overview of the management of depression in adults, and I share my experience and my understanding. By no means it is a comprehensive review of depression. I would recommend the full guidance documents from NICE, CKS guidance to those who need more in-depth info. And we will not be covering any special scenarios like young adults, children, depression in postnatal period. So we are going to learn the latest NICE guidelines in depression in adults, how antidepressants work, their effects, side effects, alternative treatments, how to choose the appropriate antidepressants and how to withdraw or change them, the patient-friendly way to explain most common questions to the patients, and finally we will go through some example cases and I will give you some references and sources of further information. So why depression is important? Why should we need to know about it as doctors and medical professionals? Depression is the most common psychiatric disorder. It affects nearly 1 in 6 people in UK. By the year 2020, depression is projected to reach second place in the ranking of disability adjusted life years calculated for all ages. It carries a high burden in terms of treatment costs, effect on families and carers, and loss of workplace productivity. Currently ranked 4th in terms of global disease burden by the WHO. Depression may not always be recognized by GPs. Depression is 2 or 3 times more common in patients with chronic diseases than in those who have good physical health. It may become a chronic disorder with ongoing disability, particularly if inadequately treated. More than 80% of patients with depression are managed and treated in primary care, with those seen in secondary care being skewed towards much more severe disease. Yes, we treat more than 80% of patients. Wow. The patient-centered care is very vital in depression. Treatment and care should take into account patients' needs and preferences. People with depression should have the opportunity to make informed decisions about their care and treatment in partnership with us. If patients do not have the capacity to make decisions, we should follow the Department of Health's advice on consent and the code of practice that accompanies the Mental Capacity Act. Good communication between us and patients is very essential. It should be supported by evidence-based written information tailored to the patient needs. Treatment and care and the information patients are given about should be culturally appropriate. It should be easily accessible to people with additional needs such as physical, sensory, or learning disabilities, and to people who do not speak or read English. If patient agrees, families and carers should have the opportunity to be involved in decisions about treatment and care. Families and carers should also be given the information and support they need. Building a trusting relationship and work in an open, engaging, and non-judgmental manner is very vital. We should explore treatment options in an atmosphere of hope and optimism, explaining the different causes of depression and that recovery is possible. We should be aware that stigma and discrimination can be associated with the diagnosis of depression. Ensure that discussions take place in settings in which confidentiality, privacy, and dignity are respected. Make all efforts necessary to ensure that a patient with depression can give meaningful and informed consent before treatment starts. This is especially important when a person has severe depression or is subject to the Mental Health Act. Ensure that consent to treatment is based on the provision of clear information about the intervention, covering what it comprises, what is expected of the patient while having it, and the likely outcomes, including any side effects. For people with recurrent severe depression or depression with psychotic symptoms, and for those who have been treated under the Mental Health Act, consider developing advanced decisions and advanced statements collaboratively with the person. Record the decisions and statements and include copies in the patient's care plan, in primary and secondary care. Give copies to the patient and to the family or carer if the person agrees. Depression is a broad and heterogeneous diagnosis. Central to it is depressed mode and or loss of pleasure in most activities. It refers to both negative affect, like low mood, and or absence of positive affect, like loss of interest and pleasure in most activities. It is usually accompanied by an assortment of emotional, cognitive, physical, and behavioral symptoms. A wide range of biological, physiological, psychological, and social factors have a significant impact on the course of depression and the response to treatment. All interventions should be delivered by competent doctors. A comprehensive assessment is needed. All interventions should receive regular high-quality supervision. Use routine outcome measures and ensure that the patient with depression is involved in reviewing the efficacy of the treatment. Engage in monitoring and evaluation of treatment adherence. In case identification and recognition, be alert to possible depression whenever you're seeing patients, particularly in people with a past history of depression or a chronic physical health problem with associated functional impairment. Consider asking people who may have depression these two questions. During the last month, have you often been bothered by feeling down, depressed, or hopeless? During the last month, have you often been bothered by having little interest or pleasure in doing things? These are the quick points in drug treatment. Do not use antidepressants routinely to treat persistent subthreshold depressive symptoms or mild depression because the risk-benefit ratio is poor. Consider them for people with a past history of moderate or severe depression or initial presentation of subthreshold depressive symptoms that have been present for a long period, at least 2 years, or subthreshold depressive symptoms or mild depression that persist after other interventions. For people with moderate or severe depression, provide a combination of antidepressant medications and high-intensity psychological intervention like CBT or IPT. During the continuation and relapse prevention, support and encourage a person who has benefited from taking an antidepressant to continue medication for at least 6 months after remission of an episode of depression. Discuss with the person that this greatly reduces the risk of relapse. Antidepressants are not associated with addiction. People with depression who are considered to be at significant risk of relapse or who have residual symptoms should be offered one of the following psychological interventions. Individual CBT for people who have relapsed despite antidepressant medication, and for people with a significant history of depression and residual symptom despite treatment. We can offer mindfulness-based cognitive therapy for people who are currently well but have experienced 3 or more previous episodes of depression. This is the definitions for depression from NICE guidance using DSM 4th edition classification. Sub-threshold depressive symptoms, fewer than 5 symptoms of depression, and mild depression, few if any symptoms in excess of 5 required to make the diagnosis, and symptoms result in only minor functional impairment. Moderate depression, where symptoms of functional impairment are between mild and severe. Severe depression, most symptoms and the symptoms markedly interfere with functioning, can occur with or without psychotic symptoms. When assessing a patient who may have depression, we have to conduct a comprehensive assessment that does not rely simply on a symptom count. Take into account both the degree of functional impairment and or disability associated with the possible depression and the duration of the episode. We have to consider any history of depression and comorbid mental health of physical disorders, any past history of mood elevation to determine if the depression may be a part of bipolar disorder, any past experience of and response to treatments, the quality of interpersonal relationships, living conditions, and social isolation. We have to be respectful of and sensitive to diverse cultural, ethnic, and religious backgrounds when working with people with depression, and be aware of the possible variations in the presentation of depression. Ensure competence in culturally sensitive assessment using different explanatory models of depression, addressing cultural and ethnic differences when developing and implementing treatment plans, working with families from diverse ethnic and cultural backgrounds. Always ask people with depression directly about suicidal ideation and intent. If there is a risk of self-harm or suicide, assess whether the person has adequate social support and is aware of sources of help. Arrange help appropriate to the level of risk. Advise the person to seek further help if the situation deteriorates. The Stift care model provides a framework in which to organize the provision of services and supports patients, carers, and practitioners in identifying and accessing the most effective interventions. In Stift care, the least intrusive, most effective intervention is provided first. If a person does not benefit from the intervention initially offered or declines an intervention, they should be offered an appropriate intervention from the next step. This is the guidance from NICE guidelines. So in step 1, we have to do the assessment, support, psychoeducation, and active monitoring, and referral for further assessment and interventions if needed. In step 2, where there is persistent subthreshold depressive symptoms, mild to moderate depression, we offer low-intensity psychosocial interventions, psychological interventions, medications, and referral for further assessment and intervention. In step 3, where there is inadequate response to initial intervention and moderate and severe depression, we offer medication and high-intensity psychological intervention, combined treatments, collaborative care, and referral for further assessment and intervention. The final step 4, in severe and complex depression, where there is risk to life, severe self-neglect, we offer, in addition to medication, high-intensity psychological intervention, electroconvulsive therapy, crisis service, and combined treatments, multi-professional and inpatient care. Yeah, we have to be alert to possible depression whenever we are seeing patients with a past history of depression or chronic health problems. And just ask these two screening questions. During the last month, have you often been bothered by feeling down, depressed, or hopeless? Or have you often been bothered by having little interest or pleasure in doing things? If the person answers yes to either of the questions, we should perform a mental health assessment and should review the person's mental state and associated functional, interpersonal, and social difficulties. We should use a validated measure to inform and evaluate treatment. For people with significant language or communication difficulties, for example, people with sensory impairments or a learning disability, consider using the distress thermometer or ask a family member or carer about the person's symptoms to identify possible depression. If you see significant level of distress, investigate further. If a person with depression presents considerable immediate risk to themselves or others, refer them urgently to specialist mental health services or crisis team. Advise people with depression of the potential for increased agitation, anxiety, and suicidal ideation in the initial stages of treatment. Actively seek out these symptoms and ensure that the person knows how to seek help promptly. Review the person's treatment if they develop marked or prolonged agitation. Advise a person with depression and the family or carer to be vigilant for mood changes, negativity and hopelessness, and suicidal ideation, and to contact us if they are concerned. This is particularly important during high risk periods such as starting or changing treatment and at times of increased personal stress. If a person with depression is assessed to be at high risk of suicide, take into account toxicity in overdose if an antidepressant is prescribed or the person is taking other medication. If necessary, limit the amount of drugs available to them. Consider increasing the level of support such as more frequent direct or telephone contacts. Consider referral to specialist mental health services. In general measures, sleep hygiene forms a vital role. Offer people with depression advice on sleep hygiene if needed, including establishing regular sleep and wake times, avoiding excess eating, smoking, or drinking alcohol before sleep, creating a proper environment for sleep, and taking regular physical exercise. For people who, in the judgment of the practitioner, may recover with no formal intervention, or people with mild depression who do not want an intervention, or people with subthreshold depressive symptoms who request an intervention, discuss the presenting problems and any concerns that the person may have about them. Provide information about the nature and cause of depression. Arrange a further assessment normally within 2 weeks and make contact if the person does not attend follow-up appointments. For people with persistent subthreshold depressive symptoms or mild to moderate depression, consider offering one or more of the following interventions guided by the person's preference. Individual guided self-help based on the principles of cognitive behavioral therapy, CBT, and computerized cognitive behavioral therapy, CCBT, a structured group physical activity program. Mood Gym and Beating the Blues are very good source. Do not use antidepressants routinely to treat persistent subthreshold depressive symptoms or mild depression because the risk-benefit ratio is poor, but consider them for people with a past history of moderate or severe depression or initial presentation of subthreshold depressive symptoms that have been present for a long period, at least 2 years, and those symptoms persist after other interventions. Although there is evidence that St. John's wort may be of benefit in mild or moderate depression, we should not prescribe or advise its use by people with depression because of uncertainty about appropriate doses, persistence of effect, variation in the nature of preparations, and potential serious interaction with the other drugs, which includes oral contraceptives, anticoagulants, and anticonvulsants. Advise people with depression of the different potencies of the preparations available and of the potential serious interactions of St. John's wort with other drugs. For people with persistent subthreshold depressive symptoms or mild to moderate depression who have not benefited from a low intensity psychological intervention, discuss the relative merits of different interventions like an antidepressant, normally a SSRI, or high intensity psychological intervention like CBT, interpersonal therapy, behavioral activation, behavioral couples therapy for people who have a regular partner and where the relationship may contribute to the development or maintenance of depression, or where involving the partner is considered to be of potential therapeutic benefit. For people with moderate or severe depression, provide a combination of antidepressant medication and a high intensity psychological intervention, CBT or IPT. The choice of intervention should be influenced by the duration of the episode of depression and the trajectory of symptoms, previous course of depression and response to treatment, likelihood of adherence to treatment and any potential adverse effects, person's treatment preference and priorities. For people with depression who decline an antidepressant, CBT, IPT, behavioral activation, and behavioral couples therapy, we can consider counseling for people with persistent subthreshold depressive symptoms or mild to moderate depression, short-term psychodynamic psychotherapy, and we have to discuss with the person the uncertainty of the effectiveness of counseling and psychodynamic psychotherapy in treating depression. Discuss antidepressant treatment options with a person with depression, covering the choice of antidepressant, including any anticipated adverse events, for example, side effects and discontinuation symptoms, and potential interactions with concomitant medication or physical health problems. Their perception of the efficacy and tolerability of any antidepressant they have previously taken. When an antidepressant is to be prescribed, it should normally be an SSRI in a generic form because they are equally effective as other antidepressants and have a favorable risk-benefit ratio. SSRIs are associated with an increased risk of bleeding, especially in older people or in people taking other drugs that have the potential to damage the gastrointestinal mucosa or interfere with clotting like warfarin. In particular, consider prescribing a gastroprotective drug in older people who are taking non-steroidal anti-inflammatories like ibuprofen or aspirin. Fluoxetine, fluvoxamine, and paroxetine are associated with a higher propensity for drug interactions than other SSRIs. Paroxetine is associated with a higher incidence of discontinuation symptoms than other SSRIs. Take into account toxicity in overdose when choosing an antidepressant for people at significant risk of suicide. Beware that compared with other equally effective antidepressants recommended for routine use in primary care, venlafaxine is associated with greater risk of death from overdose. Tricyclic antidepressants, except for lofipramine, are associated with the greatest risk in overdose. Please take the following into account when prescribing drugs other than SSRIs: the increased likelihood of the person stopping treatment because of side effects, and the consequent need to increase the dose gradually with venlafaxine, duloxetine, and TCAs. The specific cautions, contraindications, and monitoring requirements for some drugs, the potential for higher doses of venlafaxine to exacerbate cardiac arrhythmias and the need to monitor the person's blood pressure, the possible exacerbation of hypertension with venlafaxine and duloxetine. The potential for postural hypotension and arrhythmias with TCAs. This is very important in elderly patients. The need for hematological monitoring with mianserin in elderly people. Non-reversible monoamine oxidase inhibitors, MAOIs, such as phenelzine, should normally be prescribed only by specialist professionals. Desalapin should not be prescribed. When prescribing antidepressants, explore any concerns the person with depression has about taking medication, explain fully the reasons for prescribing, and provide information about taking antidepressants, including the gradual development of the full antidepressant effect, the importance of taking medication as prescribed, and the need to continue treatment after emission, at least for 6 months, potential side effects, the potential for interactions with other medications, the risk and nature of discontinuation symptoms with all antidepressants, particularly with drugs with a shorter half-life, such as paroxetine and venlafaxine, and how these symptoms can be minimized. The fact that addiction does not occur with antidepressants. This is the most common worry in most of the patients. Offer written information appropriate to the person's needs. For people started on antidepressants who are not considered to be at increased risk of suicide, normally see them after 2 weeks. See them regularly thereafter, for example, at intervals of 2 to 4 weeks in the first 3 months, and then at longer intervals if response is good. A person with depression started on antidepressant who is considered to be present at increased suicide risk or is younger than 30 years because of the potential increased prevalence of suicidal thoughts in the early stages of antidepressant treatment for this group. They should normally be seen after 1 week and frequently thereafter as appropriate until the risk is no longer considered clinically important. Side effects. This is very important subject. If a person with depression develops side effects early in antidepressant treatment, provide appropriate information. Consider one of the following strategies. Monitor symptoms closely where side effects are mild and acceptable to the person. Or stop the antidepressant or change to a different antidepressant if the person prefers. In discussion with the person, consider short-term concomitant treatment with the benzodiazepine if anxiety, agitation, and/or insomnia are problematic, except in people with chronic symptoms of anxiety. We can give zopiclone, 3.75 milligram to 7.5 milligram every night as needed for 14 days maximum. We can treat for 2 to 4 weeks, but usually should not be longer than 2 weeks in order to prevent the development of dependence for benzodiazepines. People who start on low-dose TCAs and who have a clear clinical response can be maintained on that dose with careful monitoring. If a person's depression shows no improvement after 2 to 4 weeks with the first antidepressant, check that the drug has been taken regularly and in the prescribed dose. If response is absent or minimal after 3 to 4 weeks of treatment with a therapeutic dose of an antidepressant, increase the level of support. Increasing the dose in line with the SPC if there are no significant side effects. Switching to another antidepressant if there are side effects or if the person prefers. If the person's depression shows some improvement by 4 weeks, continue treatment for another 2 to 4 weeks. Consider switching to another antidepressant if the response is still not adequate or there are side effects or the person prefers to change treatment. For all high-intensity psychological interventions, the duration of treatment should normally be within the limits indicated in this guideline, as the aim of treatment is to obtain significant improvement or remission during the duration of treatment. May be reduced if remission has been achieved, increased if progress is being made. For all people with depression having individual CBT, the duration of treatment should typically be in the range of 16 to 20 sessions over 3 to 4 months. For all people with depression having IPT, the duration of treatment should typically be in the range of 16 to 20 sessions over 3 to 4 months. For people with severe depression, consider providing 2 sessions per week for the first 2 to 3 weeks of treatment. For all people with depression having behavior activation, the duration of treatment should typically be in the range of 16 to 20 sessions over 3 to 4 months. And behavioral couples therapy for depression should normally be based on behavioral principles, and an adequate course of therapy should be 15 to 20 sessions over 5 to 6 months. In delivering counseling, for all people with persistent subthreshold depressive symptoms or mild to moderate depression having counseling, the duration of treatment should typically be in the range of 6 to 10 sessions over 8 to 12 weeks. For all people with mild to moderate depression having short-term psychodynamic psychotherapy, the duration of treatment should typically be in the range of 16 to 20 sessions over 4 to 6 months. Switching antidepressants is very important and very difficult if you don't know how to do it. When switching to another antidepressant, be aware that the evidence for the relative advantage of switching either within or between classes is weak. Consider switching to initially a different SSRI or a better tolerated newer generation antidepressants. Subsequently, an antidepressant of a different pharmacological class that may be less well tolerated, for example, venlafaxine, a TCA, or a MAOIs. Do not switch to or start dozalapine because evidence supporting its tolerability relative to other antidepressants is outweighed by the increased cardiac risk and toxicity in overdose. When switching to another antidepressant, which can normally be achieved within 1 week, when switching from other drugs with a shorter half-life, consider the potential for interactions in determining the choice of new drug and the nature and duration of the transition. Exercise particular caution when switching from fluoxetine to other antidepressants because fluoxetine has a long half-life, approximately 1 week. From fluoxetine or paroxetine to TCA, because both of these drugs inhibit the metabolism of TCAs, a lower starting dose of the TCA will be required, particularly if switching from fluoxetine because of its long half-life. When switching to a new serotonergic antidepressant or MAOI because of the risk of Serotonin Syndrome. From a non-reversible MAOI, a 2-week washout period is required. Other antidepressants should not be prescribed routinely during this period. Let's say about stopping or reducing antidepressants. Advise people with depression who are taking antidepressants that discontinuation symptoms may occur on stopping, missing doses, or occasionally on reducing the dose of the drug. Explain that symptoms are usually mild and self-limiting over about 1 week, but can be severe, particularly if the drug is stopped abruptly. When stopping an antidepressant, gradually reduce the dose, normally over a 4-week period, although some people may require longer periods, particularly with drugs with a shorter half-life, such as paroxetine and venlafaxine. This is not required with fluoxetine because of its long half-life. Inform the person that they should seek advice from the practitioner if they experience significant discontinuation symptoms. If discontinuation symptoms occur, monitor symptoms and reassure the person if symptoms are mild. Consider reintroducing the original antidepressant at the dose that was effective or other antidepressant with a longer half-life from the same class. If symptoms are severe, and reduce the dose gradually while monitoring symptoms. Electroconvulsive therapy is considered for acute treatment of severe depression that is life-threatening and when a rapid response is required or when other treatments have failed. It is not routinely used for people with moderate depression, but consider it if their depression has not responded to multiple drug treatments and psychological treatment. As set out in the introduction to NICE guideline, the assessment of depression is based on the criteria in DSM 4th edition. Assessment should include the number and severity of symptoms, duration of the current episode, and course of illness. The key symptoms are persistent sadness or low mood and or marked loss of interest or pleasure. At least one of these, most days, most of the time, for at least 2 weeks. If any of the above present, ask about associated symptoms like disturbed sleep, decreased or increased appetite, or weight loss or weight gain, fatigue or loss of energy, agitation or slowing of movements, poor concentration or indecisiveness, feelings of worthlessness or excessive or inappropriate guilt, suicidal thoughts or acts. Then ask about duration and associated disability, past history, family history of mood disorders, and availability of social support. Factors that favor general advice and active monitoring: 4 or fewer of the above symptoms with little associated disability, symptoms intermittent or less than 2 weeks duration, recent onset of identified stressor, no past or family history of depression, social support available, lack of suicidal thoughts. Factors that favor more active treatment in primary care: when they have 5 or more symptoms with associated disability, persistent or long-standing symptoms, personal or family history of depression, low social support, and occasional suicidal thoughts. Factors that favor referral to mental health professionals are inadequate or incomplete response to 2 or more interventions, recurrent episode within 1 year of last one, history suggestive of bipolar disorder, the person with depression or relatives request referral, more persistent suicidal thoughts, self-neglect. Factors that favor urgent referral to specialist mental health services are actively suicidal ideas or plans, psychotic symptoms, severe agitation accompanying severe symptoms, severe self-neglect. Discuss choice of antidepressant covering anticipated adverse events, potential interactions with concomitant medications, person's perception of the efficacy and tolerability of any antidepressants they have previously taken. Normally, choose an SSRI in generic form. Take the following into account. SSRIs are associated with an increased risk of bleeding. Consider prescribing a gastroprotective drug in older people who are taking non-steroidal anti-inflammatories or aspirin. Fluoxetine, fluoxamine, and paroxetine have a higher propensity for drug interactions. For people who also have a chronic physical health problem, consider using citalopram or sertraline, as these have a lower propensity for interactions. Paroxetine is associated with a higher incidence of discontinuation symptoms. Take into account toxicity in overdose for people at high risk of suicide. Be aware that compared with other equally effective antidepressants recommended in primary care, venlafaxine is associated with a greater risk of death from overdose. The greatest risk in overdose is with TCAs except for lofipramine. When prescribing antidepressants for older adults, prescribe at an age-appropriate dose taking into account physical health and concomitant medication. Monitor carefully for side effects. For more information on using antidepressants in pregnancy and the postnatal period, see the relevant guidance in the NICE guidelines. The appraisal of aglomelatin was terminated because there was no evidence submitted. Therefore, NICE is unable to make a recommendation about the use in the NHS of aglomelatin for the treatment of major depressive episodes. Okay, the The two key symptoms are persistent sadness or low mood, or marked loss of interest or pleasure. And we should go through these associated symptoms. NICE guidelines suggest screening in those with a past history of depression, significant physical illness, especially if it causes disability and other mental health problems like dementia. Other situations where the chance of depression is very high include Parkinson's disease, where the disease is common but often missed, dementia, where the two diseases can easily resemble each other. The postpartum period screening may show positive results in as many as 13%. Alcoholism and drug abuse. It may be difficult to decide if depression is the cause of substance abuse, but it may be desirable to treat both. And in victims of abuse, physical disease like cancer, cardiovascular disease, or diabetes, chronic pain, stressful home environments, the elderly, social isolation, unexplained symptoms. Initial screening in patients who may have depression. NICE recommends these two questions. During the last month, have you been feeling down, depressed, or hopeless? Have you been bothered by having little interest or pleasure in doing things? If they say yes to either of those questions, then following three questions should be asked. During the last month, have you often been bothered by feeling of worthlessness, poor concentration, thoughts of death? And we can use the Patient Health Questionnaire, PHQ-9. This is a 9-item questionnaire which helps both to diagnose a depression and to assess severity. It usually takes about 3 minutes to complete, and scores are categorized as minimal, mild, moderate, moderately severe, and severe depression. It can be downloaded free from the internet. We can also use Hospital Anxiety and Depression Scale. Beck Depression Inventory. And other screening tools such as Edinburgh Postnatal Depression Scale, Geriatric Depression Scale. Although screening tools are useful, they should not be a substitute for clinical judgment. The patient's history, family history, and the existence of comorbidities should be taken into account when diagnosing or assessing depression. And it's very important to remember this. Although there is evidence that St. John's wort may be of benefit in mild or moderate depression, we should not prescribe or advise its use by people with depression because of uncertainty about appropriate doses, persistence of effect, variation in the nature of preparations, and potential serious interaction with other drugs like oral contraceptives, anticoagulants, and anticonvulsants. Do not switch to or start Dozelapan because evidence supporting its tolerability relative to other antidepressants is outweighed by the increased cardiac risk and toxicity in overdose. Do not use ECT routinely for people with moderate depression, but consider it if their depression has not responded to multiple drug treatments and psychological treatment. For moderate depression for treatment with antidepressants, there should be at least 5 of the following over past 2 weeks. Weight changes, sleep disturbance, loss of interest or pleasure, depressed mood, psychomotor agitation or retardation, recurrent thoughts of death or suicide, fatigue or loss of energy, feelings of worthlessness, and poor concentration. We should know about the drug-induced depression. Over 150 drugs reported to cause depression. Example, alcohol, benzodiazepines, like diazepam, clonazepam, temazepam, and lorazepam, antipsychotics, and anticonvulsants like carbamazepine, pregabalin, antiparkinsonian drugs, anticholinergic, H2 blockers, interferons, non-steroidal anti-inflammatory, example ibuprofen, which is we have to keep in our mind. Cardiovascular drugs like beta blockers, calcium channel blockers. Antibiotics, although rare, baclofen rare. Steroids like dexamethasone, caffeine or caffeine withdrawal, and oral contraceptives. Simvastatin, dantrolene, tizanidine. So when we take the medication history, it's vital to see whether they are taking all these medications. Offer psychological therapy only unless there is a past history of moderate or severe depression, initial presentation of subthreshold depressive symptoms present for at least 2 years, dysthymia, or subthreshold depressive symptoms or mild depression persisting after other interventions, or mild depression which is complicating the care of the physical health problem. There are so many antidepressants available in the UK, like citalopram, escitalopram, fluoxetine, paroxetine, sertraline, mirtazapine, venlafaxine, tricyclics, and duloxetine. Trazodone, reboxetine, moclobemide, MAOIs like phenelzine, mianserin, St. John's wort. And these are the modes of action and receptors. You can have a look. SSRIs, serotonin reuptake inhibition, mirtazapine, and reboxetine causes noradrenaline reuptake inhibition, flupenthio, autoreceptor inhibition, moclobemide, reversible MAOA inhibition, and MAOI's inhibition of MAOA and MAOB enzymes. So discuss choice of antidepressant covering anticipated adverse effects, side effects, and discontinuation symptoms, potential interaction with concomitant medication or physical illness, the person's perception of the efficacy and tolerability of any antidepressant they have taken previously. Take into account toxicity and overdose for people at significant risk of suicide. Be aware that compared with other equally effective antidepressants recommended in primary care, venlafaxine is associated with a greater risk of death from overdose. The greatest risk in overdose is with TCAs, except for lofipramine. SSRIs are associated with an increased risk of bleeding. So consider prescribing gastroprotective drug in older people who are taking NSAIDs or aspirin. Fluoxetine, fluvoxamine, and paroxetine have a higher propensity for drug interactions. For people who have a chronic physical health problem, consider using citalopram or sertraline, as these have lower propensity for interactions. Paroxetine is associated with a higher incidence of discontinuation symptoms. The increased likelihood of a person stopping treatment because of side effects and the consequent need to increase the dose gradually with venlafaxine, duloxetine, and TCAs. The specific cautions, contraindications, and monitoring requirements for some drugs. Non-reversible MAOIs such as phenelzine, combined antidepressants, and lithium augmentation of antidepressants should normally be prescribed only by specialist mental health professionals. Dosilipin should not be prescribed. Prescribe at an age-appropriate dose, taking into account physical health and concomitant medication, and monitor carefully for side effects in older adults. These are the selected antidepressant side effects. The most common is anticholinergic, like dry mouth, blurred vision, and constipation. Cardiac side effects like prolonged QTc interval, postural hypertension, tachycardia, nausea during the initial and start with lower doses, sedation, mostly histaminergic effect. Overdose toxicity, mainly cardiac effects. Proconvulsant, when we use bupropion more than 300 milligram per day. Sexual dysfunction, like lower libido or erectile dysfunction and anorgasmia. Anxiety, short term, especially with SSRIs, appetite changes, hyponatremia, except mirtazapine. So this is very important thing to remember when treating elderly people with low sodium. Diarrhea, headache, sweating, especially at night. Many can be minimized by starting at lower doses. These are the comparative side effects of antidepressants. This slide will be very useful. And mirtazapine is found to have very less side effects and can be useful in elderly patients. And it causes sedation, so people who are finding difficulty to sleep, these tablets like mirtazapine will be more helpful. So these are the characteristics of SSRIs, like citalopram, fluoxetine, fluoxamine, paroxetine, and sertraline. You can go through this slide and make sure you remember these things. Sertraline can cause diarrhea and paroxetine cause sedation. Fluoxamine known to have gut side effects, and fluoxetine have sedation as well as skin side effects. This is a slide to let you know the usual initial treatment dose and the maximum daily dose. Like for example, citalopram, in less than 65 years of age, we can start from 20 milligram orally in the morning. If they're elderly, then we can start with 10 milligram every day in the morning. And we can go up to 20 to 40 milligram. And fluoxetine 20 milligram orally in the morning, and then we can go up to 80 milligram. And sertraline 50 milligram every day. Generally increase to 100 milligram in the morning in 5 to 7 days. We can go up to 200 milligram. And you can keep the slide and you can verify. And always, have a look at the BNF and check if you're in doubt. This is the usual therapeutic doses of SSRIs. And tricyclics. We commonly use amitriptyline in our general practice. The newer antidepressants. Nowadays we use mirtazapine more often in elderly people. For people who are not considered to be at increased risk of suicide, normally see them after 2 weeks. See them regularly, for example, every 2 to 4 weeks in the first 3 months, and then at longer intervals if response is good. For people who are considered to be at increased risk of suicide or younger than 30 years, normally see them after 1 week and then frequently until the risk is no longer clinically important. If a person experiences side effects early in treatment, provide information and consider monitoring symptoms closely if they are mild and acceptable to the person, or stopping or changing to a different antidepressant if the person prefers, or short-term concomitant treatment, usually no longer than 2 weeks with the benzodiazepine if anxiety, agitation, or insomnia are problematic, except in people with chronic symptoms of anxiety. Use with caution in people at risk of falls. People who start on low-dose TCAs and have a clear clinical response can be maintained on the dose with careful monitoring. Antidepressants do not take 4 weeks to work. 23% of all drug placebo differences occur within the first week, and 57% were apparent by week 2. Time to substantial remission may take four weeks in clinical trials. In 90% cases, substantial improvement occurs within the first 2 weeks, but that of the benefit continues to build over several weeks. If improvement is not occurring on the first antidepressant after 2 to 4 weeks, check that the drug has been taken as prescribed. If response is absent or minimal after 3 to 4 weeks of treatment with a therapeutic dose of an antidepressant, increase support and consider increasing the dose in line with the SPC if there are no significant side effects, or switching to another antidepressant if there are side effects or if the person prefers. If there is some improvement by 4 weeks, continue treatment for another 2 to 4 weeks. Consider switching antidepressants if the response is still not adequate, or there are side effects, or the person prefers to change drug. The chances of success with increasing dose is limited. Ssris, generally side effects limited, and mirtazapine, we don't know. Possible success in tricyclics, but the side effects increase, and MAOIs, side effects and toxicity increase. Probable success in venlafaxine, and side effects increase. So we should know why to discontinue or switch antidepressants. Lack of efficacy, adverse effects, patient discontinues of own accord, and end of maintenance phase. These are the most common reasons why we discontinue or switch antidepressants. While switching antidepressants, the factors need to consider the speed at which the switch is needed, current dose of the first dose, individual drugs, effects, transmitter effects, kinetics, etc., individual susceptibility to addictive side effects. Potential problems like cholinergic rebound, antidepressant discontinuation symptoms, drug-drug interaction, discontinuation effects from first drug interpreted as side effects of the second, serotonin syndrome for drugs affecting serotonin. So this slide is very important to keep in mind while switching antidepressants. So this is rough guidance. If you're changing from short-acting SSRIs to other antidepressants like another type of the same SSRIs or fluoxetine, mirtazapine, it will give a rough idea about what we need to do. So you can go through this, and you can always, keep it in your room and have a look. Always, check with the BNF and MIMS. Clinical guidance, CKS will give more information as well. You can get more information from the Modelist Prescribing Guide on www.nhsevidence.nhs.uk, bnf.org.uk, or medicines.org.uk. This is the slide for adverse effects. So we can make sure to go through this. SSRIs most commonly cause gastrointestinal effects like diarrhea. Many drugs cause insomnia. Let's see the Serotonin Syndrome. It is a toxic state caused by an increase in brain serotonin activity. The symptoms are In neuromuscular, restlessness, myoclonus, tremor and rigidity, hyperreflexia. Other symptoms like shivering or elevated temperature, arrhythmias, and it can be fatal due to cardiac collapse. It's a syndrome caused by overstimulation of serotonergic mediated innervation in the central nervous system. Combination of antidepressants, either deliberately or accidentally, may cause Serotonin syndrome. Onset is usually within few hours of dose changes and can resolve quickly on dose reduction or cessation once symptomology recognized. Diagnosis is according to Sternbach's criteria as below, like at least 3 mental state changes: agitation or restlessness, sweating, diarrhea, fever, hyperreflexia, tachycardia, myoclonus, lack of coordination, shivering, and tremor. Nausea, vomiting, tachycardia, hypertension, and convulsions have been reported. Rule out other causes of these symptoms such as infection, substance misuse, or withdrawal or neuroleptic malignant syndrome. Most often with combined or consecutive treatment with SSRIs, tricyclics, MAOIs, and tryptophan, etc. The treatment, first of all, stop drugs usually resolve in no more than 24 hours, and symptomatic measures like cooling, benzodiazepines, and it can be prevented by taking care when combining or switching serotonergic antidepressants. Let's see the discontinuation phenomena. It commences within 1 to 3 days of stopping or reducing doses, usually short-lived, 1 to 2 weeks. Rapidly suppressed by reintroduction of drug, distinct from relapse or recurrence, which occur more than 2 weeks after discontinuation, can occur even with missed doses. And tricyclics can cause headache, restlessness, diarrhea, nausea, flu-like symptoms, cramps, lethargy, sleep disturbances, and movement disorders. And venlafaxine may cause fatigue, headache, restlessness, nausea, abdominal distension, congested sinuses. And SSRI discontinuation can cause dizziness, lightheadedness, sleep disturbances, agitation, electric shocks in the head, nausea, fatigue, headache, flu-like symptoms, and mirtazapine, reboxetine can cause very little or nothing reported with mirtazapine. This is very important to keep in mind while prescribing elderly patients. Mirtazapine is better tolerated. MAOIs cause confusion, delirium, and psychosis. Encourage a person who has benefited from taking an antidepressant to continue medication for at least 6 months and inform them that this greatly reduces risk of relapse, and remind them that antidepressants are not associated with addiction. This is the most common concern from the patient's point of view. So let them know that antidepressants are not associated with addiction. Duration of treatment: if at high risk of relapse, we usually advise use of antidepressants for at least 2 years. Maintain level of medication at which acute treatment was effective. The person has had 2 or more recent episodes of depression which cause significant function impairment, and they have other risk factors for relapse. The consequences of relapse are likely to be severe, and after 2 years, reevaluate treatment with the person, taking into account age, comorbidities, and other risk factors. Thereafter, reevaluate as regularly as needed. Right, let's see the example cases. Let me have some water. Question number 1. A 39-year-old woman has been taking fluoxetine 20 mg for moderate to severe depression for 2 months. She feels better and now wishes to stop. What's the best advice? Continue for 6 months and then stop. Reduce slowly over 4 weeks. Reduce to 10 milligram for 6 months and then stop. Stop today. Stop and refer for CBT. What will you do? Yes, continue for 6 months with the same dose and then stop if she's okay. Now, the question number 2. A 70-year-old lady comes to see you in 3 weeks after her husband's death. You notice she looks depressed. She reports poor sleep, appetite, loss of pleasure in activities, and feelings of depersonalization. What would you suggest? Is sertraline better? Metazapine is a choice, or St. John's wort with light counseling therapy, careful monitoring and bereavement counseling, or any combination of above. Think about the scenario and what would you do? What is the best option for her? Yes, you're right. Because of the recent bereavement, we have to carefully monitor her, and we can offer bereavement counseling. Question number 3. A 30-year-old female patient has been taking citalopram 40 milligram daily for 4 weeks for moderate to severe depression. She doesn't feel there is much improvement. She has suicidal thoughts, but they are transient. She has a history of drug overdose. She has refused psychological treatment. So what would you do in this scenario? Would you start her on amitriptyline, or would you just continue the citalopram? Would you consider sertraline, or would you refer her to a psychiatrist, or would you prefer metazapine in this case? Think about the scenario. Right, metazapine is better tolerated, and it might be the best option for her. And as she is already on maximum dose of citalopram, we can consider metazapine in this case. The QOF scheme requires practices to assess depression using a validated questionnaire. Select the single most correct statement regarding the PHQ-9. Assesses mood over a 6 months period. Can quantify anxiety levels. Used for screening rather than diagnosis. Measures severity of depression. And it should be filled in by the doctor and the patient together. Yes, PHQ-9 measures severity of depression. Right, we have come to the conclusion. Let's recap some of the important points. Depression is a chronic condition, and antidepressants are effective in acute depression. It prevents relapse. They are not addictive nor dependence prone. It helps to correct a chemical imbalance, have no major documented long-term harmful effects, appear to be widely used suboptimally. Education about antidepressant use should be integral with all prescribing as it improves attitudes and hence concordance. We have got easy to navigate nice flow diagram online. And these are the resources you can go through. Depression in Adults Nice Guidelines, CG90, and British National Formulary. And these are the websites you can go through: patient.info, NHS Clinical Knowledge, PHQ9, patient.co.uk. It's very, very beautiful website with information in simple language. And MIMS switching between antidepressants. This is very valid link when we are considering switching the antidepressants. And the Scottish Intercollege Guidelines Network SIGN guidelines for non-pharmaceutical management of depression. So, well done. We have come to the end of this webinar. So just, make sure you do the screening questions. And if shows possible depression, then go for PHQ-9 questionnaire and ask core symptoms and additional symptoms. And if more than 12 or more than 12 scores in PHQ-9, it's a threshold for treatment. Then assess the risk of suicide. Ask all suspected patients about suicidal ideation and current intent at assessment, follow-up, and initiation of dose changes. Just ask these questions. Do you ever think about suicide? Do you have the means for doing this available to you? Have you made any plans for ending your life? What has kept you from acting on these thoughts? These are the vital questions to assess their suicidal intent. And for step 1, offer them careful monitoring. And in step 2, just go for the low intensity psychological interventions and assess. And if there is inadequate response after 3 to 4 weeks, then you have to reconfirm diagnosis, check the compliance with medication, then review the psychological interventions and consider offering high intensity psychological intervention in addition to treatment. Check using therapeutic doses and optimize medication regime where appropriate, and always refer to the latest BNF for current dosages. And continue the treatment for 6 months after the first episode. If it's recurrent depression, continue for 2 years and reassess. So these are the main important points. And in step 3, moderate and severe depression, if there is no response to step 2, then you can go for offer high intensity psychosocial intervention like CBT and IPT and antidepressant medication. The first line, I would advise to try low-cost SSRIs like citalopram or fluoxetine. The treatment threshold is where there are 12 or more scores in the PHQ-9 out of 27. And it's a second line treatment if unable to tolerate citalopram or fluoxetine or no response to those medicines after 6 weeks. You can consider trying alternative SSRIs like sertraline, paroxetine, or fluoxetine, or alternative antidepressants such as mirtazapine at night. And in the third line treatment, if they are not tolerate the treatment or no response to the second line drug treatment within 6 weeks, then we can offer considering venlafaxine, immediate release tablets, or augmentation strategy. But these should be done by the specialist mental health professionals. And if you think it's a severe chronic resistant depression or high risk of suicide or children or adolescent or inadequate response to step 3, refer to the specialist intervention. So always go through your local guidance and follow that. And the few points to remember is all SSRIs like escitalopram or citalopram increase the QT interval. Where possible, avoid other QT interval prolonging drugs or monitor ECG. And be careful while the patients have renal liver impairment, and in elderly patients, always start at low dose and increase slowly. And if the patient have cardiovascular disease, then consider mirtazapine as first line. In cerebrovascular events, consider sertraline as first line. And patients with seizures, avoid TCAs. You can use SSRIs. If the patient has got increased risk of bleeding, you can consider mirtazapine as first line. And you can also consider adding a low-cost PPI like lansoprazole when using other antidepressants. All antidepressants may increase the risk of suicidal ideation in children and young adults, so monitor closely. Fluoxetine should be used first line. And always monitor sodium, because risk of hyponatremia with all antidepressants, especially in elderly and those with low BMI, they are prone for hyponatremia, so keep an eye on sodium. And while you're stopping or switching antidepressants, refer to Maudsley prescribing guidelines or CK's depression prescribing information. Check the BNF. And if you're seeing this video in my blog, I will leave you some links and PDF to download, so you can go through that. And that's it. And all the best. And you can do it. So all the best for your exams if you're having your exams in the near future. And good luck. Okay, keep in touch. And if you're in my blog, you can go for the free video trainings, and you can even get my free book download. You can see the options in the homepage and on the right side of your screen. So get those free gifts from me, and well done. See you. Bye-bye.